A very good evening from India and a warm welcome to all of you to this 15th edition of TUGSS Endoscopy Academic webinar. So continuing with our mission of being a platform for learning and promotion of GI endoscopy, especially among surgeons, we are pleased to have with us today a stellar group of endoscopists who are going to enlighten us about the technique of image-enhanced endoscopy. So basically, by utilizing advanced imaging techniques such as narrowband imaging or chromoendoscopy, image-enhanced endoscopy actually enhances the visualization of the mucosal and vascular patterns of the GI lesions, leading to improved diagnostic yield and thus enabling us to go in for an earlier intervention, which basically benefits the outcomes of the patients. So to kickstart the session today, I would first request Dr. Path to introduce our chairpersons for the session. Dr. Path, over to you.
Thank you. Firstly, I am honored to invite our first chairperson for the day, Dr. Satish Mida. Sir is a consultant at Vivekanand Hospital in Ranchi. He's working as a laparoscopic GI surgeon and an endoscopist, and he has a leadership role at ASI Jharkhand, and sir is the president-elect of IAGS Executive Committee 24-25. He has been training many surgeons in lots of advanced laparoscopic skills, and we are happy to have you over here. Welcome, Dr. Satish Mida. Nextly, I would like to invite, and I'm pleased to invite Dr. Sunil Kumar Sharma Dakal. He is heading the Department of GI and General Surgery at Nepal Medicity. He has been working in the capacity as a consultant GI and laparoscopic surgeon since 1998. He went on to pursue laparoscopic fellowship training in South Korea and Singapore for 6 months duration in advanced cancer surgery, and he has taken leadership in the progression of advanced laparoscopic surgery in Nepal and has been actively involved in teaching as well as learning as well as surgical practice. And he is the official trainer of J&J Basic Surgical Course, and he has co-edited and published multiple books and scientific articles. Welcome, we are pleased to have you, sir.
Thank you very much.
And I'm also very pleased to invite Sajida Qureshi ma'am. She is the consultant at General Surgery Department at Aga Khan University in Pakistan. She has completed her fellowship with the Royal College of Surgeons in Ireland and her fellowship of the College of Physicians and Surgeons in Pakistan. She has underwent training by doing a fellowship in upper GI and bariatric surgery at the Salford Royal Hospital, Manchester from UK, and has also done a fellowship with the recent trends of breast oncoplastic techniques at the Paris Breast Center in 2009. We are very happy to have you, ma'am.
Thank you very much.
Over to Dr. Bhavnit.
Thank you, Path. Thank you for the introductions. Thank you. So I would now like to introduce the guest speaker for the day, who is none other than Professor Amol Bape. Dr. Bape actually needs no introduction. So he's a consultant gastroenterologist and interventional GI endoscopist and heading the Department of Digestive Diseases and Endoscopy at Dinath Mangeshkar Hospital and Research Center, a post which he has been shouldering the responsibility of for over a decade now. Professor Bape has special interest in EOS, ERCP, third space endoscopies, and actually has a long list of firsts to his name. He is credited with the first to report a ESG procedure, POEM procedure, EOS guided drainage procedures in this part of the world. Professor Bape has held leadership positions in GI endoscopic societies across the world and is a widely published author too. It's a pleasure to have you with us here today, sir. I would request you to start your talk now. The screen is all yours.
Good afternoon, everyone. Am I audible and are my slides visible there?
Yes.
Perfectly fine, sir.
Right. So thanks to the TUGSS India group and particularly Dr. Balla, and I can see a lot of friends over here in the group, and I'm sure many other people will be joining here. So thanks for this kind invitation. And today's topic that we're going to cover in the next 30 to 40 minutes is image-enhanced endoscopy, some principles and applications that we would share. And so let's start with basically the incidence and mortality of GI cancers and what is it that we have over here? So are we missing early cancer is the question that many of us as endoscopists definitely need to ask. And or I would say actually, as all clinicians, we need to ask this question that are we missing early cancer, particularly in the GI tract? So whenever we're talking about image enhanced endoscopy, we need to understand that this is primarily designed to diagnose early cancers in the GI tract, and that is what we're going to be discussing about. And that's the reason I put this slide as the first slide. And we can see over here that the lack of early detection of GI malignancy and the 5-year survival rates of GI cancers, we can see based on the stage of the cancer, the survival is really drops down significantly, and it's dismal for stage 4 cancer, as we can see. And at the same time, what we can see is in Japan or in some of the Western countries, the incidence of early cancer is improving. And that means that patients are getting diagnosed with early cancer much more commonly. And because of which they can be offered more curative resections, either endoscopic or surgical, and they have a better prognosis. So that is the reason we need to understand the principles of this. So when endoscopy started about 70, 80 years ago, so in the 1950s, the smallest size of the early gastric cancer that could be diagnosed was about 2 to 3 centimeters. From there on, there have been tremendous developments in imaging technology and the microscopic and the zoom technology, everything, to the extent that today we can diagnose microscopic cancers with reasonable ease using some of the techniques that we're going to be discussing in the next few minutes now. So this is how endoscopy has evolved in the diagnostic area as well as in the therapeutic area. So in the diagnostic area, we can see beyond the surface, not on the surface only nowadays. And then therapeutic, we can resect many of these cancers which are endoscopically resection is possible by ESD techniques. So that is what is important. So we are going to focus only on the diagnosis today. So endoscopy is the main instrument when we're talking about screening for GI cancer, and that we know. So at the same time, when we use and when we are conventionally using our white light endoscopy, we need to understand that there are certain limitations. And early cancers typically are difficult to detect by conventional endoscopy. So we can see over here a subtle mucosal change, pattern change, and a vascular color change over here could be a heralding early cancer. And similarly over here, these subtle changes can actually indicate that this could be cancer. Small flat lesions like this may be difficult to detect on colonoscopy or a conventional colonoscopy, but using some image enhanced technology, we can improve this. So methods to enhance endoscopic image detection and diagnosis. There are several methods that are available: magnification endoscopy, chromo endoscopy, autofluorescence imaging, which nowadays is no longer being used, and narrowband imaging. Or narrowband imaging is a proprietary name, but there are comparable to narrowband imaging with other manufacturers as well. And this basically is called digital chromoendoscopy. So in chromoendoscopy, what we do is we spray actual dye on the mucosa. But digital chromoendoscopy is just by pressing of a button, and we'll come to that in a while, that we can get the same kind of imaging. And then there are some other techniques as well. So today we are going to be focusing mainly on narrowband imaging or the digital chromoendoscopy, because that is the most important and the most commonly used technique worldwide currently. So what are the factors which improve diagnostic performance for early cancers? So what we need is an endoscope which actually has magnification capability, and it also has spectral imaging or narrowband imaging. That is what is most important. So we've been talking about narrowband imaging. What is this narrowband imaging? So we know that the white light consists of the entire spectrum, and the wavelength we know is from 400 to 700 nanometers, and it contains all the 7 colors of the spectrum. the blue light has the narrowest wavelength and the red light has the highest this thing. And based on the wavelength, the penetration of this light is different. The other important thing is that the affinity of the hemoglobin in blood vessels for blue and green light is much more as compared to the red light. Using this technology, what is done in narrow imaging is that there is a blue and green filter which is applied so that the red light is completely cut out and the surface of the mucosa is examined using a blue and green filter, which gives us a characteristic pattern, and that is how it looks like. So this is what happens in your endoscope. You have the xenon lab, and then you have the NBI filter, and then this is the rotary filter. But once you turn the NBI filter on, only a narrowband image is produced as compared to the conventional white light image, as we can see over here. And here we can see some mucosal surface and the vascular surface anatomy over here. And you can see that using the narrowband image, this white light image is so much well enhanced, and we can see the vascular pattern much more clearly over here. And we will come to the vascular patterns in a while, so as to describe and classify them in different types. So just to give you an overview of how this looks, I've just borrowed this clip from a movie. And here you can see that using different spectrums of the light, you can see the visualization can be changed. So this is how it can actually change. Now, the role of NBI for detection of early malignancy in the esophagus, stomach, and colon. So in the esophagus, we can detect early squamous cell cancer, dysplasia, and Barrett's. In the stomach, it's early gastric cancer, and for colon, it's surveillance and detection of polyps and cancer. So let's come to them organ-wise, and let us deal with each one of them. So in the esophagus, there is a submucosal vein, and we have to look at the vascular pattern. So we have a submucosal vein which has an oblique running vessel, and then there are these intraepithelial papillary capillary loops, and these are the capillary loops, and then there are branching vessels over here. But this is the end point, and this is the target vessel which is seen in the epithelium. Now, using an NBI image, you can see these IPSCLs as brown dots over here. You can see over here, these are the brown dots, which are the IPCLs. And these IPCLs form a pattern which is very characteristic in different conditions, which can be utilized. And this technology can be utilized, and this classification can be utilized to diagnose cancer or non-cancerous lesions. So IPCLs can come in different varieties of shapes and sizes. So the first change in the IPCL pattern can be just a simple dilatation of the IPCL pattern, where the capillary loops dilate. Then you may have tortuosity. Then the caliber change can be there. So the caliber of this thing can, the IPCL can change. And then you can have an irregular or various shapes of the IPCL pattern. And based on that, we can have a classification. So whenever we try and assess the IPCLs, we look at the dilatation of the IPCLs. We look at the meandering, or meandering means actually just wandering away. So that kind of an IPCL, if there is a caliber change, and if it is a non-uniform pattern. So these patterns are what are most important. So the classification of IPCL comes as 1, 2, 3, 4, and 5. And then the 5 is further subdivided into multiple types. So 1 is the normal pattern, or just a little bit of a corkscrew, but 2 is just elongated. IPCL, you will again have type 3, you will have this pattern. And the type 4, there is a little bit of dilatation of the IPCLs. But type 5 onwards, you have dilatation, irregularity, and meandering, and form variation as well. And this is the type 5.1, and then 5.2, 5.3, and this is the VN or 5N, which actually denotes new tumor vessel generation, which indicates deep submucosal invasion. So that is what detects this thing. So the spectrum in how do we look at the pattern and how does the epithelial pattern look in different conditions in the esophagus. So non-erosive esophageal reflux. So this is the normal pattern, and you can see that even in non-erosive GERD, where there may not be any obvious erosions on white light, if we apply in the NBI, we will see that the IPCLs have increased in number, they're elongated and darker, and they are a little bit dilated sometimes and tortuous, but they are uniform. You can see that this is uniform. There is no abrupt change in the pattern which can suggest that there is a cancerous transformation. And here we can see that the sensitivity and specificity and this thing is quite, and the accuracy of diagnosing NERD in patients using an NBI pattern is quite significant as compared to control groups. And here we can see that in patients with reflux disease, GERD, NERD, reflux esophagitis, and Barrett's esophagus, we can see comparison with healthy controls. We can see that the epithelial tortuosity, microerosions, round pit pattern below the squamocolumnar junction and below the non-round pit pattern can all have characteristic identifications and accuracy patterns. So another picture which I'm trying to show you, this is a little bit of an advanced inflammatory process. So we can see that this pattern is uniform and on the lateral sides, but in the center, it becomes a little bit non-uniform. And this is at the G junction. We are looking at a Barrett's area. But within the Barrett's area, we can see that this is quite uniform, except for this area. But at this point over here, where arrows have been marked, you can see that there is a little bit of a loss of pattern, and that is where one should focus the biopsy form. So what we do is, whenever we are looking at these patterns, we try and look at the areas which are most suspicious for cancer or dysplasia, and then accordingly we may either target that area for biopsy, or the other thing is what we might do is we might even if we are 100% sure about the diagnosis, we may also obviate the need for biopsy, and we can directly proceed with endoscopic resection if the lesion is amenable for endoscopic resection. That is how it happens. Now, this is again severe esophagitis, and we can see that this is still very much inflammatory. So these patterns there is a little bit of ulceration over here, and that is the reason the pattern has changed. But you can see that till the end of the edge of the ulcer, the pattern is quite uniform over here. And that indicates that this is still inflammatory and not neoplastic. So these are some of the caveats that we have to look at when we are looking at the esophageal this thing. Another area where we can see, again, a Barrett's esophagus with a little bit of change. But this is again inflammatory because we are seeing a uniform pattern over here. So how do we look at these patterns? So the first is we look at the type of the mucosal pattern. We look at flat or other. Then we look at the regularity of the pattern, whether it is regular or irregular. Then we look at the vascular pattern. After the surface pattern, we look at the vascular pattern, whether it is regular or irregular. And within the regularities, then we look at the types of vessels. And then we we try and identify whether there are any abnormal vessels. And if there are any abnormal vessels, then the type of abnormal vessels are looked at. And that will give us a diagnosis of cancer, because these are the ones which are high-grade dysplasia or neoplastic lesions. So that is what we have to look at. So this is again an example. Now there is a nodular lesion over here in the esophagus, which is clearly seen on NBI. And initial examination, it could be a cancer, but you can see over here that the IPCL pattern is quite regular, and the final histology is actually a papilloma. It is not a cancer over here. So that actually helps us make the diagnosis. So this is the IPCL pattern again, and here you can see that based on the IPCL pattern, one can decide whether the lesion is inflammatory or whether there is low grade or high grade intraepithelial neoplasia, or whether there is cancer, intraepithelial cancer, or whether there is deep invasive cancer which requires surgery. So based on the IPCL pattern, one can actually determine the treatment that can be offered to these patients. Now coming to the magnification NBI for esophageal squamous cell cancer. So here we can see that now this is a cancerous lesion. Now here we can see that the vessels are dilated, they're irregular, and also there is a clear-cut demarcation line between the normal and the abnormal. And this actually indicates cancer. The IPCL can also determine the depth of invasion, as we saw earlier. And this is an intraepithelial neoplasm. But here we can see that there is more irregularity and there is a thin branch-like vessel pattern, which indicates that there is invasion of the muscularis mucosae. And this is a thick non-loop vessel, which is actually a new vascularization caused by the cancer, which indicates deep submucosal invasion. So based on this, we can diagnose the depth of invasion as well. Here again, we can see this is intraepithelial, but here there is loss of, there is an avascular area in between, but it is still quite small. Whereas here it is a wider area, and there this could be submucosal invasion. So based on these two patterns, one can determine that whether there is submucosal invasion or not. And the accuracy and the sensitivity of magnification with NBI for predicting invasive depth is quite accurate. The specificity is quite high. The sensitivity is quite average. And based on this, it can give us definitely a superior diagnosis as compared to just a white light imaging. And this was another single center study which showed us that comparing to standard chromoendoscopy using Lugol's iodine, if we compared white light, narrowband imaging, and Lugol's iodine, the sensitivity, the accuracy of white light was the lowest. Over here, the sensitivity was the lowest. Although Lugol's was the highest, NBI came a close second. And overall, the accuracy for NBI was the highest, which was close to this thing. So that is how it was. So these are some of the statements of the guidelines. So NBI is useful for detection of esophageal squamous cell cancer, and magnification NBI can differentiate esophageal neoplasia from non-neoplasia, and it helps to determine the extent of the cancer, as well as helps to diagnose the tumor depth of the cancer. So these are some of the pre-malignant conditions, and just this is high-grade intraepithelial neoplasia, or a high-grade dysplasia, as we might call it, but not actually cancer, because here we can see that the patterns are still reasonably regular, but we can see the demarcation line over here. So coming to Barrett's esophagus, now we are going to take esophagus, squamous cell, then Barrett's, then stomach, and then colon. If there is any this thing, I will, I'll be happy to take questions after that. So Barrett's esophagus, there are various classification systems. The Kansas or the Amsterdam or the Nottingham patterns, basically based again on the mucosal pattern or the pit pattern, the vascular pattern, and presence or absence of abnormal vessels. So wherever we are talking about image-enhanced endoscopy, we talk about the surface or the mucosal pattern, vascular pattern, and then presence of abnormal vessels. So these are some of the pictures. We can see that this is a normal columnar epithelium, but with Barrett's over here. So this is the ridged appearance of the Barrett's. And here we can see that there is, again, this is quite normal. This is non-dysplastic Barrett's. But when we are looking at another picture over here, so here we can see that the surface pattern as well as the vascular pattern is quite regular. This again, although it is a villous or a gyrus appearance of a pit pattern, it is still regular. But over here, we can see that the surface pattern is absent, the vascular pattern is a little bit irregular and crenated, but it is still regular overall within this field of view. So you're not seeing one area of abnormal vessels over here, as you can see over here. Here you can see that there is definite a demarcation line followed by this part and this part. The vascular pattern is completely irregular, as well as this part, the vascular pattern is quite regular. So this kind of a amorphous or a variegated appearance will definitely give us a diagnosis of cancer as compared to this kind of a pattern, which indicates actually atrophic gastritis within the Barrett segment also. And we'll come to that when we discuss the stomach part. So, and this will show us some low-grade dysplasia, but this is definitely high-grade dysplasia or cancer. So that is how it is going to differentiate, help us differentiate these lesions. So coming to vascular changes, and I'm sure Dr. Mida is there. So this is actually named after Dr. Mida only. So there is a meandering path of the vessels that it may take, irregular caliber of the vessels, then the deranged shape of the vessels, a heterogeneous appearance, and altered density of the vessels. So that is what actually indicates cancer in these patients. So here you can see all those patterns are there, and this is an area of cancer. And this is white light, no doubt about that. And we can identify this lesion over here, but one can interrogate it in more depth. And you can also see over here that the demarcation line is much more extensive as compared to what is seen on just the white light. Again, you can see the gyrus pattern of the Barrett's over here. And without the magnification, this looks quite normal. But when we magnify, you can see that there is a single focus of irregular vessels over here in the center. I don't know whether you are able to see my cursor, but I'm pointing to that. And that is actually a small focus of cancer within this Barrett's. And that is what is very useful. So we can use magnification and narrowband imaging to our advantage to diagnose such early lesions. Now let us come to the stomach. And let us start by asking us the question why we should be diagnosing early gastric cancer. And that is basically because early gastric cancer, once it spreads to the SM2 layer, the incidence of lymph node metastasis is 15 to 20%. But before that, the risk of lymph node metastasis is practically zero. So that is the reason it gives us an opportunity to perform endoscopic resections and also offer curative resections for these patients when the lymph tumor has not metastasized to the lymph nodes. And the other reason is because early gastric cancer is a very slow growing process. The opportunity for diagnosis, treatment, and surveillance goes over a very long period of time, because from normal to an acute gastritis, then atrophy, metaplasia, dysplasia, then we have a well-differentiated cancer, which further may progress to a poorly differentiated cancer. And at all these points in time, on the timeline, we can perform screening endoscopy to detect for early cancer or dysplastic lesions. For that, we need to understand the anatomy and how it looks on narrowband imaging. So the stomach anatomy is different in the fundus and different in the antrum. So in the fundus, you have these pits, which are hexagonal pits. We can see over here, these are the hexagonal pits with the subepithelial capillary, and then the crypt, that is the central crypt opening with the marginal crypt epithelium. And these are some of the terminologies that one needs to be familiar with when we are describing nerve and imaging images. So you have the submucosal venule, the submucosal arteriole, and the fundic gland, all these things. And when we come to the antrum, you have a ridged kind of a pattern over here. But otherwise, the pattern remains practically the same, because only thing is you cannot see the central pits as compared to in the fundus over here. I'm going back a slide. Here we cannot see the central pits, but we see a ridged kind of a pattern over here. So this is normal. And when we know what is normal, then we can detect the abnormal much more easily. Let us come to some of the terminologies: the subepithelial capillary network, crypt opening, collecting venule, marginal crypt epithelium, intestinal metaplasia, light blue crescent, white opaque substance, and demarcation line, as I mentioned earlier, also in the esophagus. So this is the normal surface and vascular pattern in the stomach. This is in the fundus and body. This is in the antrum thing. And then when we come to H. pylori gastritis, this is the typical picture in H. pylori gastritis. You can see a leathery appearance, and the pits are quite dilated and open. You can see over here that the pits are quite open, but it's still a very regular appearance. And this is how a chronic atrophic gastritis looks. So this is a patch which looks pale. And then when on magnification endoscopy, we can see that the vascular pattern is branch tree-like, and it's irregular and heterogeneous with wide areas of avascular areas in between, but it is still reasonably regular. So there is currently no dysplasia, but atrophic gastritis, there is a high propensity for developing dysplasia in future. So these patients have to be screened properly. Coming to intestinal metaplasia. So when we diagnose intestinal metaplasia in the stomach, we have to look at oval or tubular gland-like features. So these are oval or tubular-like tube-like glands. Then this can be focal or multifocal. And the vessels actually become obscured, and you start getting these light blue crests. So these are the light blue crests which are around the pits, and these are actually characteristic of intestinal metaplasia. And if in presence of LBC, we have to say that this is intestinal metaplasia even without a biopsy. It is that pathognomonic. So this is how a multifocal intestinal metaplasia looks on white light and then on narrowband imaging. And then on further magnification, we will also see the light blue crests. And NBI for non-neoplastic gastric pathology, when we look at the sensitivity and specificity, it is quite high for normal H. pylori as well as intestinal metaplasia, all three of them. So whenever we do an endoscopy in the stomach, what are the steps? We inspect with white light imaging, we perform a classification. We first look at the demarcation line, and then we do a white light and NBI assessment, first of the surface, then of the vasculature, and then we assess for depth and differentiation. So this is a benign gastric ulcer. And why is it benign? Because you can see that the surrounding the ulcer, the pit pattern and the vascular pattern is uniform till the edge of the ulcer. As compared to that, this is an early gastric cancer. And here you can see that although the ulcer is only central, very small over here, the pit pattern and the vascular pattern has changed for a considerable distance around the lesion, around that ulcer. And this definitely indicates that this is a cancer, an ulcer cancer, rather than just a benign ulcer. So whenever we are doing a gastroscopy, we have to assess these patients for the cancer risk. So A and B are the normal gastric mucosa, but C has H. pylori gastritis and D is atrophic gastritis. And as we discussed, atrophic gastritis has the highest cancer risk. So we have to examine these patients more carefully. So when we look at early gastric cancer, we look at the change of color, elevated or depressed lesions, and we also have to insufflate the stomach well. We have to look at the line of demarcation. We look at the abnormal or obscured surface pattern and also the abnormal vessels. So this is how a color change looks. A subtle color change on white light, and then a demarcation line which is seen on the narrowband imaging very clearly. You can see the demarcation line over here, and this is the cancer. A very subtle change from from the intestinal metaplasia that we can see in the surrounding mucosa. But this is IM without dysplasia, and this is definite dysplasia, because you can see that the pit pattern and the vascular pattern has changed in this area. We can also have elevated and depressed lesions in the stomach, and these will look like this on white light, and then when we interrogate on NBI, this is how it looks. After looking at the surface and the elevated depressed lesions, what we look at the surface pattern and the vascularity. So the surface pattern here is irregular over here. So this is the normal, and this is the irregular depressed area. And we can also see that there is a demarcation line over here. Similarly, over here, there is a demarcation line over here, and the vascular pattern in this area, we can see spindle-like vessels and irregular vessels. Here also, the vascular pattern is quite okay, but there is a depressed lesion and the surface pattern has changed. Here, both the surface as well as the vascular pattern, all four have changed in the D. So that is how we can classify and differentiate a normal from an early gastric cancer. So early gastric cancer can also come in two morphological types. Sorry. We can either have the gastritis or the diffuse type, or we can have the polypoidal or the ulcerative type. The polypoidal is further classified according to the Paris classification in this manner. And then when we are talking about the microvascular and the micro surface pattern, this is another place where you can see the demarcation line very clearly. And then this is the demarcation line, and you can see within the demarcation line, the surface pattern has changed, the micro surface pattern has changed, and also the microvascular pattern has changed. Here there are dilated vessels, here the vessels are sparse, here again there are dilated vessels. So there is patchy vascularization, and which is classical of early gastric cancer. Again, some pictures to show the differentiation between a regular pattern versus an irregular pattern. And here I come to the white opaque substance. So sometimes on magnification endoscopy, we see this white opaque substance. What happens is, if there is white opaque substance, this is deposited within the mucosa, the microvascular pattern sometimes gets obscured. But because the microvascular substance gets is obscured and the white opaque substance is there, we can almost invariably say that there is dysplasia in this region, and these are the areas which need to be targeted for biopsy or resection. Again, coming to the surface pattern over here, this is regular as compared to the irregular pattern over here, and then this is again micro capillary examination, magnification examination, where we can see that the vascular pattern, you have irregular spindle-shaped vessels over here like this, coming to the center, and that indicates malignancy. So that is what I was talking about, the white opaque substance, and it predicts the irregular microsurface or the microvascular pattern based on the distribution and deposit. So if this substance was deposited uniformly, then we can say that the surface pattern is also quite uniform, but otherwise we have to say that it is irregular. There are further subclassifications where the vascular pattern may be like a fine network, which is a differentiated adenocarcinoma, or it may be a corkscrew pattern, which indicates an undifferentiated adenocarcinoma. And mind you, all this is without histopathology. We are not taking biopsies. This is based on only surface and vascular patterns. So this is the algorithm for detection of early gastric cancer. Whenever there is a suspicious lesion, we first look at the demarcation line. If it is absent, then obviously it is non-cancerous. But if it is present, then we look at the irregular microvascular pattern. If irregularity is not present, then it is non-cancer. But if it is present with a demarcation line, it is cancer. Mark you, demarcation line is important because in certain inflammatory conditions, you may get irregular microvascular and microsurface pattern in the absence of demarcation line, and that indicates inflammation and not cancer. That is very important. And of course, we have endocytoscopy now, which has come up in a reasonably big way. So this is normal, where you can actually see the cellular level, and this is an irregular cell morphology over here, which indicates that the nuclei are quite prominent over here because of more DNA over here, and that is what indicates malignant process. Coming to the colon and rectum, colorectal cancer, we know, is the third leading cause of cancer death worldwide. And untreated polyps more than 10 millimeters have a 25% chance of harboring invasive cancer at 20 years. And although we know that the polypectomy can reduce the risk by half, we need to implement screening colonoscopy and also surveillance in the lower GI for maintenance of good health and also prevention of colorectal cancer. And here again, the anatomy is important to understand. So this is non-invasive, so intraepithelial neoplasia, so you can have low-grade or high-grade or non-invasive cancer based on where it lies. So this is the lumen, and then you have the mucosa, high-grade dysplasia. Then you have a carcinoma in situ, but a carcinoma in situ which is going up to the M2 or M3 layer, up to the muscularis mucosae. And then we have submucosal invasion, either into the SM1, SM2, or SM3 layer. It is important to understand that the lymphovascular plexus resides in the SM2 layer, because of which what happens is a cutoff of 1000 microns is important. If the tumor depth is less than 1000 microns, then it is amenable for endoscopic resection because it has not metastasized. That is what has been hypothesized. And the lymph node metastasis risk is much lower in an SM1 lesion. So this is how we differentiate. So these are the lesions which are amenable for an EMR, and SM1 invasive cancers are amenable for ESD, and deeper invasive cancers require surgery. So there are several classifications in the colorectum as well. And they're again based on the color, vascular, and surface pattern. I'm going to touch upon the NBI related classifications over here. But to characterize, again, we have to perform the wide field view and then the focal interrogation. So in the wide field view, we first perform the Paris classification and we look at the granularity. So in the Paris classification, this is the macroscopic appearance in white light. Remember, so we have to look at the polypoidal or the non-polypoidal variety. And then in the polypoidal, whether it is protruded, pedunculated, or sessile. And then we have the non-polypoidal variety, which is superficial elevated, flat, or superficial depressed, like these. These are the examples over here. And based on that, there are some algorithms because which have a higher incidence of deep invasion. So this is based on morphology. And then we also look at the granularity of the surface. So this is a granular lateral spreading tumor in the rectum. So we know that many of the polyps in the rectum, particularly in the rectum and in the colon, can grow laterally, and these are called lateral spreading tumors. And this is a granular tumor. This again is a granular tumor. As compared to this, we can see that the surface is quite uniform, and this is a non-granular lesion, and this again is a non-granular lesion. And why this is important is because morphology, based on the morphology of the Paris classification and the granularity, a 2A granular type of lesion, the risk of deep submucosal invasion is very low, around 2%. But the same for a Paris 2A plus 2C and a non-granular variety, the risk is very high, around 67%. So that is how it is. And also, whenever we are looking at lateral spreading tumors, we have to know where the invasion can lie. So in a granular tumor, lateral spreading tumor, it can lie under a large nodule, or in a non-granular lesion, it can even be multifocal. So the importance of this is that when we resect these lesions, they have to be resected en bloc. So these lesions cannot be subjected to a piecemeal EMR. They have to be subjected to an ESD where you can get an en bloc resection. So that is what is important. Coming to the focal interrogation, which we can perform after performing the wide field interrogation. So we look at the mesh brown capillary pattern using the narrowband imaging or the other modalities, and the Kudo pattern also for chromoendoscopy, but we will not discuss that today. Coming to the NICE pattern, this was the first classification for a colorectal polyps using the NBI classification, which classified into type 1 and 2 and 3. So type 1, it is based on the color, vessels, surface pattern, and based on that, if the color is comparable to the surrounding mucosa, and the vessels there are no vessels or very few isolated lacy vessels, and there are few dark white spots of uniform size or a homogeneous absence of the pattern, then these are usually hyperplastic or sessile serrated polyps. However, if the surface is browner as compared to the surrounding mucosa, as we can see over here, and there are brown vessels surrounding the white structures, or if there are oval or tubular branched white structures with brown vessels, then this is a adenoma without dysplasia, or a low risk adenoma as we call it. Whereas a type 3 is again a brown this thing, but it has areas of disrupted or missing vessels, and the surface pattern will actually be an amorphous pattern, or there is no surface pattern at all, and which indicates deep submucosal invasive cancer. So this was the first classification. It is very useful even today. Only thing is, its limitation is that it cannot differentiate between an adenoma with dysplasia. So something between 2 and 3, it cannot differentiate between these two. So, and that can sometimes impact the treatment strategy. So that is the reason the Japanese NBI group came out with this classification. So this is divided into type 1, type 2A and 2B, and then we have type 3. So type 1 is comparable to the NICE. Type 3 is again comparable to the NICE, where you have deep submucosal invasive cancer with amorphous areas and interruption and thick vessels. But type 2A is divided into A and B, where in type 2A, you have regular vessels and regular distribution of the vessels, whereas in type 2B, you have irregular or obscured vessels and the distribution is not uniform, which indicates this is high-grade dysplasia. So lesions which are type 2A can be subjected to piecemeal EMR, but lesions with type 2B have to be subjected to an en bloc resection, preferably using an ESD. So that is the reason we have to differentiate between the two. So this is how we can, another example of a JNET classification. So this is normal. This is 2A, this is a polyp, but without any dysplasia. This is dysplastic polyp, and this is possibly deep invasion. So that is how it indicates. I will just tell you what the pit pattern, the Kudo pit pattern means, because this has been used for all the classifications, the NICE, the Kudo, and the JNET both. And so you have type 1, 2, 3S and 3L, and then 4 and 5. And these are the pit patterns that can be seen. And when we compare the JNET with the Kudo pit pattern, we can see that these lesions can be left in situ because they are hyperplastic. These require, the 2A require endoscopic resection. 2B further may require further chromoendoscopy for evaluation of depth of invasion, and may require endoscopic resection or surgical resection based on their depth of invasion. So this is how the JNET classification actually helps us to differentiate these polyps. Therefore, even in the colorectum, we have to implement a 3-step strategy. First, we use white light and we use a target NBI colonoscopy. We identify the lesion. Then we use NBI, first look at the capillary pattern, whether there is a demarcation line, whatever there is may be, and then based on that, we further perform chromoendoscopy if required to determine the invasiveness or the non-invasiveness of the lesion and then decide the strategy for resection. This is a video which I'm just going to play, which shows small polyps actually and cold smear EMR for the polyps, but it demonstrates the NBI evaluation very carefully, very effectively. So here you can see that careful examination with NBI is being performed. Always take a still image when you examine and use water flushing and use an underwater imaging technique to identify this thing. So here you can see that this is a 2A pattern on JNet. So this can be resected using a cold snare technique. And now let us come to the next lesion. Now this is another lesion. Again, a small lesion. Again, we are examining it. The pattern looks quite uniform as compared to the surrounding areas. And the vascular pattern, the color you can see is comparable to the surrounding mucosa. The vascular pattern is not thick meshed or something like that sort, which indicates this thing. So this is hyperplastic polyp, so it can be left alone. Again, this again is a hyperplastic polyp, can be left alone. So this is how we can actually differentiate different lesions. So in one patient, actually, there is one adenoma, but there are multiple other hyperplastic polyps. So NBI to differentiate neoplastic versus and non-neoplastic colorectal polyps. This was a meta-analysis of diagnostic operating characteristics of more than 6,000 polyps in 4,000 patients. And NBI diagnosis was found to be highly accurate. Area under the curve was more than 0.9. And the confidence prediction was very high, more than 90% in most operator groups as well. And now we also have computer-aided colorectal tumor classification, where based on computer algorithms, it can give us the risk of adenoma detection and whether the adenoma is high risk or low risk. There are several algorithms that are available with Olympus, Fujifilm, all of them, which actually predict, and you get the immediate diagnosis or the prediction on the screen as you're performing the colonoscopy. So this is where future is going, where you have AI detected diagnosis as well. So with that, probably I will give you some take-home messages. Whenever we're performing image-enhanced endoscopy, we need a systematic three-step approach. We need to be patient and obtain good still images. And it is a no-brainer here that we need a good bowel preparation so that our image-enhanced endoscopy can be utilized to its maximum. And that is important for the colon, no doubt, but it is also important for the upper GI. Because of want of time, I did not discuss how we can actually improve our upper GI imaging as well, but that may be taken up at some other time. Then we need to review and compare multiple images to understand the nuances of all these classifications, because otherwise they can get very confusing. So basically, we have to remember mucosal surface pattern, vascular pattern, and demarcation line. These three things are very important. And of course, we can use online resources, take expert opinions as required. And it's okay if we make mistakes. Initially, we can make mistakes and also classifications have their limitations. But what is important to understand from an endoscopist point of view, that we should avoid taking random biopsies now. They are obsolete. Even if you have to take biopsies, take targeted biopsies based on your NBI assessment. And avoid biopsies in non-neoplastic conditions. And also for non-neoplastic, biopsies which may not give us a yield. And very often, if we improve our NBI skills and the image-enhanced endoscopy skills, we can get a real-time diagnosis, a real-time therapy, and that is actually what is important. With that, I will take your leave and I'll be happy to take any questions. Thank you so much.
Thank you, Professor Bape sir. That was indeed a very wonderful and a comprehensive talk. And thank you for showing us so beautiful slides and helping us understand actually the entire scope, the depth of image enhanced endoscopy, if I may say so. So we are almost out of time, but I'm sure we can have a few more questions, and we can start with the comments from our or queries from our chairperson, Professor Sunil, Professor Sajida. Would you like to go ahead?
Yes, a wonderful talk, Dr. Amol. I really enjoyed your talk thoroughly, and it has just opened up my mind about narrowband imaging totally. In Nepal, we do have a lot of gastric cancers, and although hereditary diffuse gastric carcinoma is not that common, we have quite a number of sporadic cases. And when the family comes to screening, I see a lot of patients with multiple metaplasic foci. Now, how often should I be doing narrowband imaging on these chaps? That's my first question. And
Okay.
The second question is, yes, in narrowband we do pick up the metaplasia, but where else should I be taking biopsies from apart from these places?
Okay, so now the first part of your question. So these patients are basically patients with a family history of gastric cancer. So
Yeah.
they are a high risk group, and if they have metaplasia, now metaplasia actually does not mandate
cause.
biopsy in itself, because metaplasia can be very well detected on narrowband imaging. And when I say NBI, let me correct myself that we need to have magnification NBI. Just NBI very
Okay.
often falls short. So we need magnification NBI, because sometimes the subtle differences of the light blue crest and other things may not be visible, and the subtle microsurface and microvascular patterns may not be visible just on narrowband imaging. So if you have a metaplastic area, what is important to do is examine that area in more detail using narrowband imaging, using magnification, and then try and identify irregular areas within that metaplasia, which could be actually markers or pointers that this could be a dysplastic lesion over part over. And then if you want to target your biopsy, you can target your biopsies over there, or you could even proceed with endoscopic resection directly if you're confident of the diagnosis. That's how it is.
Thank you. And how often should it be done? That's my second question.
Okay, so
yeah.
yeah, so just the presence of metaplasia once in 3 years. If there is no dysplasia, then once in 3 years. But if there is dysplasia detected on earlier
Of course.
endoscopies, then the frequency of screening goes much, maybe even every year or so.
Yeah, so my second question was to be, but you've answered in your slides. I was thinking, for a simple guy like me, a surgeon, is there an AI algorithm that I could put on? And you did answer that, yes, it is coming up. And that's going to make our life so much easier, because what you've shown, sometimes all the patterns, it may be difficult for us to memorize. And unless you really practice just endoscopy, it may be very difficult to kind of classify these and recognize them. Thank you so much. But just a fantastic, fabulous talk. It was just enthralling. The last 50 minutes was just enthralling. Thank you so much, sir.
Thank you so much.
Thank you.
Thank you.
Thank you. Professor Sajida, would you like to come in?
Yeah, thank you very much, Dr. Amol, for a very enlightening talk, and it was very, very informative as well. Just taking up a point for the beginners, and especially surgeons who are beginning to do endoscopies, there are just two queries that I would like to put forward. One is that you said that lesions which are clearly visible on white light have to be evaluated. So I was just wondering about lesions which are very early and which are not very discernible on white light endoscopy. So would you recommend that all the patients undergoing endoscopy should have some sort of a complementary image enhanced endoscopy done, especially for very small lesions which are like flat or slightly elevated or slightly depressed, not easily discernible on white light endoscopy, number one. Number two, you also mentioned that it can be used, image enhanced endoscopy can be used to comment on the depth of it. So how would that compare with the endoscopic ultrasound findings? Or would you say that two would be complementary to one another?
Okay, thank you. Excellent questions. So let me begin with the first one. So see, we need to understand one thing, that white light endoscopy and narrowband imaging is both complementary to each other. Now, there have been multiple studies on comparing white light with narrowband imaging. Now, detection of lesions, may they be small, subtle, or larger ones, actually the outcomes are comparable whether you're using white light or narrowband. There is not much of a difference, or there is no statistical difference. But once you detect a lesion, then narrowband imaging comes into play, magnification comes into play, because then you need to characterize the lesion more effectively so that you can make a diagnosis over there. For to improve your white light imaging diagnosis, I would actually want to add a few points over here, and particularly for the upper GI. One is the prep. So these patients need to be given simethicone and N-acetylcysteine. The stomach needs to be distended, insufflated adequately so that the folds are flattened out. The minimum duration that the endoscopist should be spending inside the stomach is 7 minutes. We all are aware of the minimal withdrawal time for colonoscopy, but the gastroscopy withdrawal time is also 7 minutes. We need to be aware of that. And using that, and there are a lot of other things as well, but that is another talk, because that would have taken up a lot of these things. That is the reason I left that out today, because that would be another talk. But that is very important, that we should not be doing these 2-minute noodle endoscopies. So it is not Maggie endoscopy. It's not a 2-minute endoscopy. Spend adequate time and make every endoscopy count. That is what is important. And unless the endoscopist goes in with that thought process, we're going to miss a lot of these lesions. That is what is important. The other question, if you can repeat it further. Yeah, endoscopic ultrasound versus this. So, okay. So it differs, and it based on the organ. In the esophagus and in the colorectum, magnification NBI and the IPCL and the JNET patterns actually are adequate, and they are actually superior to endoscopic ultrasound for depth of invasion assessment. And that is they're adequate. In the stomach, unfortunately, the NBI and magnification NBI cannot predict the depth of invasion. And in these situations, we can use a radial endoscopic ultrasound probe, and understanding very, very well that unless you get a perfectly perpendicular view, you may overstage the tumor. So we need to get perpendicular views so that we don't overstage the tumor, but then we can do that.
Thank you very much.
So I'm afraid we have actually overshot our time. So we'll have to wind up the session right now. If there are any more questions, we will just put them across to the speakers and the chairpersons through email, and we'll revert back to you on them. So I'd just like to end the session here. And since there are a lot of beginner endoscopists also who are joining us today, so I think the highlight would be that it's time now to stop taking random biopsies. We should spend time within the stomach, as Professor Bape has just told us, at least 7 times if we are really interested in picking up those early lesions. And NPI is a technology which is wonderfully, going to help us in increasing our diagnostic yield of endoscopies. So I think with that, I would like to thank Professor Bape for this really enlightening talk. And thank you for all our chairpersons for joining us. As always, we have recorded this session and we are going to upload it on our YouTube channel very soon. I'll keep you posted about that also. And hope to see all of you sometime in the future once again. And we'll end the session here with that. Thank you so much.
Thank you.
Professor
Thank
Bape.
you. Thanks
Thank you,
for having
Professor
me.
Sunil.
Thanks for having me. Thank you.
Thank you,
Bye.
Dr. Sai.
Thank you. Thank you very
Good day.
much.
Pleasure.